Hi, everyone. We are going to go ahead and get started. My name is Caitlin Neese, and we are very excited for this webinar tonight. On behalf of Tactile Medical, I want to thank each and every one of you for joining us this evening. As you all know, October is a very special month as it is Breast Cancer Awareness Month. So Dr. Davis and I would like to thank all of the attendees tonight for the invaluable role that you all play in patients' lives. You cure cancer and you truly impact every life that you touch, so thank you. Tonight, we are thrilled to have Dr. Davis educating us on his decision to treat lymphedema patients and how he implemented a survivorship pathway in his breast surgery clinic. Dr. Davis, welcome, and thank you for educating us and sharing your wisdom with us. One thing I do want to mention is at the end of tonight's talk, we will have time for questions. So any questions that you have during Dr. Davis's presentation, please go ahead and put those into the Zoom chat.
Thank you, Caitlin, and thank you all for joining us this evening. So today I'll talk about breast cancer survivorship in my practice, and I want to have a discussion around lymphedema. So my name is John Davis, as Caitlin discussed already. I'm primarily in Arizona, in Gilbert, under the Arizona Center for Cancer Care and Comprehensive Breast Center of Arizona. So I mainly work in the East Valley, and these are three of the hospitals that I primarily work out of. Disclosure, so I'm a speaker for Tactile, which is why each and every one of you are here. Thank you again. I also speak for Ambry Genetic Testing and a speaker and consultant for BARD.
So tonight we're going to do something a little bit different. Dr. Davis is actually going to share his story and his why with all of you. And I think, as we know, every clinician has a story of how they ended up treating patients in the first place and maybe why they chose to treat oncology patients, and just everything that they went through to get there and how they are where they are at today. So Dr. Davis, you do have a really unique story. Would you mind sharing your journey with us?
Yeah, so I grew up in the inner city of Chicago, Illinois, and through that time, we weren't that wealthy. We lived in the projects, and I felt we didn't have the same access and care as everyone else did. Growing up, my family eventually moved to the suburbs. We had a better life out there, and eventually going to the medical school, residency, and then I did my fellowship at the Mayo Clinic in Minnesota. There is essentially kind of where I learned majority of the breast skills that I have. When I started practice about 3 years ago, Dr. Carney is one of the speakers, and I went to his talk, and I actually really enjoyed that talk during that time. He had a nice survivorship story with him. He had a lot of pictures and had a lot of evidence and data of why lymphedema is important and how the impact of Tactile really helped his patients. The name of my group is Arizona Center for Cancer Care, but under the umbrella is Comprehensive Breast Center of Arizona. And I felt that in my group, we really weren't doing lymphedema care. And how could we be a comprehensive center if we didn't offer comprehensive care, which included lymphedema treatment and things to help with lymphedema? That was really my journey and how I started at that time. Ever since then, I started using Tactile. I had a lot of great feedback. Patients come and actually love it. And throughout this talk, we'll go over different things, how the process goes from start to the end, and I'll be able to answer any questions you all have afterwards. So the agenda for today, and I'll answer all of these questions throughout the talk. And if I don't get to it, then at the end, we will go over it. So who is responsible for what? What that means is what clinician or provider is responsible for actually ordering any device, ordering physical therapy, putting these patients with CLTs and connect them to the right process. How and when should we screen for lymphedema? How do we diagnose and treat lymphedema? We'll talk about the dual referral method a little later on, and then we want to make sure that patients are not slipping through the cracks. And then as far as patient outcomes, so outcomes prior to implementing a survivorship model. So some of you may have a survivorship, some of you may not. Outcomes after focusing on survivorship and lymphedema, quotes from patients, and then my advice of where to start and how we can help. So just to take a look at breast cancer prevalence. So in 2020, the most common cancer overall is breast cancer. This was identified and found that there are more people being diagnosed with breast cancer every day. If we take a look at this 5-year survival rates of breast cancer, so from the SEER database, which is a database that looks at oncology in general, when we look at overall, when we look at localized breast cancer, which is just breast cancer that's actually in the breast. Next, they looked at regional breast cancer, so breast cancer with regional metastasis in the lymph nodes. Then they also looked at distant metastasis, so any breast cancer that is outside of the regional lymph nodes. When they looked at the 5-year data with that, so localized, so at the 5-year mark, 99% of these patients were alive. If they had any lymph node metastasis, 86% of these patients were alive. And any distant metastasis, 30% of patients were alive. But when they combined everything and looked at everything in total, for all comers with breast cancer, what they identified was that 91% of these patients were alive at 5 years. A study out of Moffitt in Tampa Bay, Florida, they extrapolated this data a little bit more. So at the 5-year mark, what they identified something around the same, with 90% of patients were still alive, all the way until 15 years. So these patients that are being diagnosed with breast cancer and treated at all stages, 80% of those patients are alive at 15 years. The reason this is important is because these patients are being treated for being diagnosed with breast cancer, being treated, and they actually have side effects. One of the side effects is lymphedema, and we'll talk about that. So what is lymphedema? If we take a step back and look at the function, I really break this down into 3 things. So the balance of fluids and drainage from the interstitium, absorption of fats and vitamins within the intestines, and the main thing we really think about is immune surveillance, so fighting off infections. So what is lymphedema from a basic foundation? So the malfunction of the lymphatic fluids responsible for moving fluids from the fluid tissue into the interstitium, and really the imbalance of the loading capacity as opposed to the transport capacity, whether that's the decreased number of lymph nodes with surgery, and then the functional status of vessels and lymph nodes with surgery as well. If we take a molecular look at this, so on the far left, we'll see that the normal lymphatic, if we take a cross-section of it, once you have an injury from surgery or trauma, what happens is you get this stasis. So the fluid is not able to move. You get these dilated capillaries, which cause duct ectasia. With that, the lymphatic system has a compensatory mechanism which forms muscle, and this is when you start to get this fibrosis in this area. So what happens is this compensatory mechanism, you get this hyperplasia, which transforms into muscular conductive from the lymphatics, and then it goes into a sclerosis period. During that period, you have decreased permeability, so fluid is not able to escape or get within the lymphatics, and then you get this bidirectional flow. So the progression from stage 2 to stage 3, eventually to stage 4, is all through this process. So if we look at the types of injuries that can occur to cause lymphedema, so if we think about this, the presence of a tumor in the body of the lymphatics affects the movement. Think about surgery. If we do a sentinel lymph node biopsy or axillary lymph node dissection, what we're doing is we're removing lymph nodes from under the arm. Anytime you have any trauma to the lymphatic system, you can have lymphedema. Usually what I quote is about 5 to 7% of lymphedema with the sentinel lymph node biopsy, and 25 to 30% with axillary lymph node dissection. If we go to radiation, when I think about this, I think about 3 different things. So anytime you get radiated, you have this decreased lymphatic proliferation. So in order for the lymphatic to grow and improve, radiation stops that. You also have this fibrosis, as we talked about before. So anytime you have radiation, you have this increase in interstitial fibrosis, which also leads to this mechanical insufficiency. So the lymphatic fluid is not able to move forward. One thing I don't think a lot of people realize is that taxane-based chemotherapies, so any chemotherapy with the taxane derivative in there, you actually decrease the peripheral system, and this also affects the lymphatic system as well. So with this, you don't have as much propulsion with taxane-based chemotherapies. We all know that an independent factor is BMI over 30 as well. So any patient with an increased BMI, anything over what we say is 25 to 30, has an increased risk of lymphedema. This was an interesting study from the Journal of Clinical Oncology. This was about 3,000 patients, and what they looked at was blood draws, injections, number of flights, and duration of flights. There's this misconception out there that if you have axillary lymph node dissection or if you have a sentinel lymph node biopsy, that you should not get any blood draws on that side, blood pressure cuffs on that side, any IVs. You shouldn't be on any flights, whether that's a short flight or a longer flight. What this study proved was that there was no significant association between the volume change of that extremity or based off of the number of blood draws, injections. They looked at flights, 1 to 2 flights compared to more than 3 flights. They also looked at the duration of the flight as well. So if you're doing a shorter flight or a longer international flight. Other factors associated with a greater increased risk is BMI, as we talked about, axillary lymph node dissection. So removing that entire lymph node basin from under the arm, regional lymph node radiation. This was probably one of the most important factors with lymphedema as well, and then cellulitis. So anytime you have an infection to that extremity, then you also have a hit to that lymphatic system. So the conclusion that they found out was that all of these were misconceptions. So you are able to get blood pressure measurements, you are able to travel, you are able to get blood draws and IV sticks. Just to take a step back, my patient population, any patients that come in, what I usually do is I talk to them and I say, I would prefer you to use the unaffected arm, but if all else fails, you aren't able to get a blood draw on that arm. If there's any issues with the blood pressure cuff, then you can use the affected arm. So treatment that may result in lymphedema. As we discussed earlier, so axillary lymph node dissection is essentially in the axillary triangle, we remove every single lymph node in that basin compared to sentinel lymph node biopsy, which we essentially cherry pick lymph nodes. When we look at the prevalence of lymphedema, and we'll just have a question right here. So what is the prevalence of lymphedema with axillary lymph node involvement?
We'll give it just a second for the answers to come in. Okay, so it looks like the group is thinking 30%.
Right. So 30%, 40% are the top two. So let's go over this. So the important thing to really understand about this is that it's not necessarily a fair question, but if you just think about cancer within the lymph node, but also the adjuvant treatment afterwards. So we know that patients that have axillary lymph node involvement, they are getting radiation for sure, and they may or may not get chemotherapy. So those essentially add to it. The answer to this is 40%. Essentially from 3 different studies, we kind of look at different things right here. The answer to the question is the last one, so 40% with lymph node involvement, but that actually accounts for adjuvant radiation and potentially adjuvant chemotherapy as well. One thing that I think is important when we think about lymphedema overall, what we really think about is extremities, so upper extremities, lower extremities, but in my field with breast cancer, we know that breast lymphedema, truncal lymphedema is also an important thing as well. So even if you don't have any axillary surgery, you still can have breast lymphedema. So patients that I treat with DCIS, they will have breast surgery followed by radiation. I'll see these patients immediate post-op doing well, 3 months later, 6 months later. So usually around that 6-month mark, when they follow back up with me, what I noticed essentially before I was sending them out to Tactile and having these compression garments, were that these patients were having what looked like this poterange. We'll have a couple pictures later on, but these patients will have this poterange type breast. And what I identified was that these patients were actually having lymphedema of the breast, of the trunk. Every patient that I have that comes to my clinic, usually I have them take off the garments from the waist up, do a thorough front and a back exam as well, looking at their trunk, the breast, and extremities. It's very easy to identify extremity lymphedema, but it's very hard to identify truncal lymphedema. The one thing I really think about with this is that you don't know what you don't know. And if you aren't looking for truncal lymphedema or breast lymphedema, then you really are missing a subset of patients. So in this study, they had about 47% of patients that actually had truncal lymphedema or breast lymphedema. This was an interesting study, and what this was showing was the lymphatic flow after a trauma or surgery to the breast. So patient A, if we take a look at, and I'm not sure if you can see the arrow, but these two highlights in A on the right side, what we really identified, those are the hot spots where they got these ICG injections. And really what those black lines are essentially are lymphatic collecting vessels. So that you get an injection with ICG and it goes through the breast. So this patient in A did not have any surgeries, no trauma to that area. So what you see is the flow, it's a still picture, but flow went into the breast and left the breast without any issues. Once we get down to patient B and patient C, is that you still have these highlights from the ICG injections, but what you really see is this dermal backflow of lymphatics. So the lymphatics are able to get to that traumatic area, but they are not able to escape based off the injury and essentially lymphedema. So how does lymphedema present in breast cancer patients? So when looking at lymphedema and staging the progression of what stage would you consider the fibrotic stage? So we'll do the same thing as we did with the last question.
Okay, so looks like the audience is thinking stage 2. Are they correct?
Absolutely. They are correct. So if we take a look, and this is kind of one of those rote memorization things, and I think that our audience has a fair amount of knowledge in lymphedema. So as we look at the progression of lymphedema, so what we really want to do is identify these patients in stage 0 or stage 1. These are really where we can have reversal of symptoms, prevent progression, and really improve quality of life. So patients, and I'll kind of take a second to talk about this. So patients that usually come to my office, so if they are having surgery, then essentially that's kind of one insult to the lymphatic system. If they have radiation, that's the second assault. And then any lymphatic surgery as well, that's kind of a third one. So any patient that comes to my clinic, I do surgery on them. And then they come in their postoperative period. I know they're having radiation or I know they're having chemotherapy. I usually do this dual referral to tactile and physical therapy, occupational therapy, and if we have a CLT in the area, we usually do that as well. So these patients that come in, they don't have any external signs of lymphedema, but I do know that after we have this accumulation of assaults and injuries to these patients, that they have a higher potential to actually get lymphedema. So our job is to really identify these patients in stage 0 and stage 1. I don't think that clinicians do a good enough job in this area. If I kind of take a look at what I was doing beforehand, when I was at the Mayo Clinic, we essentially had our tumor board, our comprehensive multidisciplinary teams. They would see the physical therapist. That we actually had a lymphedema clinic there. So they would see the breast surgeon, the radiation oncologist, the medical oncologist, the plastic surgeon, and they would go to a lymphedema clinic. They would have their prehab, they would have their rehab, and these patients would get in prehab, they would get their arm measurements or circumferential measurements during that time. But I think that us as clinicians don't, and especially in the private practice world, don't refer enough and refer early enough. So what we do is once we see it in the stage 2 and stage 3, which is really irreversible, we're sending them at a later stage when it's really difficult for you all to treat them at that point, when we should do a better job and send them in earlier. So stage 0 and stage 1 are really those early phases where we can reverse these symptoms. Stage 2, as 61% of you all got this correct, is really that fibrotic stage. We can't really reverse these symptoms, but really it's just more managing the symptoms and maintaining and trying to improve quality of life during that time. Once you get to stage 3 and stage 4, in reality, I've probably only seen about 2 or 3 of these patients, and most of these patients actually had surgeries in the 1990s, never had any CLTs back then, never really had any compression garments or decongestive therapy. These patients are just out here living, and I feel like we do a disservice because we really kind of play this hot potato game at this times where I would see the patient, I would say, all right, well, you'll see medical oncologists every 3 months, maybe they'll do it. And then you'll see the radiation oncologist, maybe they'll do it. And what I found out was that they'll come back to me a year later and they'll be in stage 1 lymphedema, and nobody's really referred them to physical therapy or tactile or CLT. And really, all of us essentially failed the patient because it's, you do it, maybe you do it, maybe you'll do it. And nobody was really doing it at that time. But I think that us as clinicians really have to refer to you all a bit more earlier and often.
Dr. Davis, we did have a question come through, and it's one that we hear commonly. So what about axillary swelling on the non-involved side? So patient presented like this, they only had mastectomy on that side. Nodal removal and radiation was on the opposite side, and she was referred for lymphedema on non-involved axilla.
The lymphatic system is a redundant system and dynamic in general. It's really hard to essentially, if they didn't go to prehab beforehand and didn't have any R measurements, it's really difficult to say that, hey, this is a little bit different than before. If they are getting treated for that affected side, maybe it is backflowing to the other side. That is a really good question, because when we look at the device, this tactile FlexiTouch later on, what we did take into account, the company took into account, was really kind of have that unaffected limb having compression as well over there. So is it possible for it to migrate or transfer over? I'll say a small amount, but at the same time, it's really hard to actually have objective data if you really haven't went to prehab or had those circumferential arm measurements on both sides.
Okay, thank you.
All right. So when we think about signs of lymphedema, and as the question was asked, so this to the far left really is a patient who's immediately, post radiation. You still see some of these sunburn or radiation damages, but this is essentially the start of lymphedema. So the patient had surgery, they had axillary surgery, now they have axillary radiation. We know that this patient has a high propensity to get lymphedema. If we take a look at that second picture to the left, this is a classic example of this kind of truncal or back lymphedema. It's hard, half of these pictures are really just of kind of the affected side, but if you really compare both sides, you do see that this is a little bit larger in general. So this patient had breast surgery, but really has as you were talking about before, the contralateral side can be affected. The ipsilateral side can be affected as well. So it is a redundant system, but you can have some backflow issues as well. This middle picture essentially is kind of a stage 1 lymphedema overall. Really, you see the affected limb on the left side is really a little bit swollen. The second to the right is a picture of podorange. So as we talked about earlier, these patients have lymphedema of the breast. This is a classic picture of lymphedema of the breast right here. These patients should have some decongestive therapy, MLD, and then this is the affected extremity of the arm as well to the far right. As we take a look at the progression overall, so far left, immediate post-op radiation, but even with some treatment, you still get some lymphedema to the far right as well, as this progression of increased lymphedema slowly progresses. As I talked about earlier, I usually do a full thorough exam with these patients. One of the things, so the bottom left, that's the classic podorange type picture of breast lymphedema. One thing that you really will see when we look at patients overall with breast lymphedema is this edematous interstitium fluid. So what you'll see is that you'll see this kind of interstitial fluid overall, and these patients will have some indentations of the breast. So they will have the same bra on that they wore before surgery, before radiation, and these patients will have this edema. The classic example of doing a good thorough physical exam with these patients, saying, all right, something is different between these patients. In the middle, you see this truncal lymphedema a little bit more on the right side than the contralateral side.
I think this information, Dr. Davis, is so important because for so long, clinicians have only talked to their patients about the arm or have screened for the arm. So I always recommend teaching through both pictures and through symptoms, because that could mean different things to different people. And then really identifying, who in the clinic wants to provide this education and who is going to be screening each one of these areas with the patient to ensure they're catching that lymphedema early on, like you mentioned. So thank you for sharing that.
Absolutely. And as you mentioned real quick, so I think that one thing to talk about my practice overall, um, you know, Tactile, they have a system in place, and I really appreciate this system. Um, the way it usually works in my clinic is that I'll see a patient initially for their breast cancer. Sometimes patients are overwhelmed, and we can talk about that later. But I do bring up lymphedema. It's not the mainstay of my talk. So I talk about their receptors. I talk about the type of surgery they can have, if they need chemo, if they need radiation. So I have a lot to talk about and fill in at that point in time. I do have staff that mention lymphedema. We talk about it, but that's not the mainstay of the conversation. I see them for a pre-op appointment, and then really my immediate post-operative appointment. And mind you, this is kind of how we do it in my practice, but that immediately, post-op period is where me, as a provider, where I sit down and have this long conversation and say, lymphedema based off if you have any adjuvant radiation or any chemotherapy, this is really your risk of lymphedema. At that point, I essentially send them out, and I do this dual referral system at that time. So they will go to a therapist, and they will have a tactile device at that time. I'm in Arizona. We have plenty of hospitals, plenty of physicians, plenty of therapists overall, and but there are some patients who come from 2 or 3 hours away who don't have a therapist immediately available for them. And I think that having this device is kind of that bridge between seeing a therapist, 2 to 3 times a week, to seeing these therapists every other week or so. Instead of having them drive 2 to 3 hours every trip, this device really does kind of have a impactful impact on these patients overall. And we'll have a couple studies talking about that. When we look at the NCCN guidelines overall, the important thing is that NCCN is essentially the Bible of oncology. And they even mentioned, I think one talk at the bottom right here. So consideration of a compression garment, MLD and pneumatic compression for ongoing hormone management. So just as I talked about before, some patients may not want to drive an hour or two. Some patients may not have transportation. And I think that having these home devices really does help overall. Really, early detection, diagnosis is really key for lymphedema management, as we talked about. Finding these patients with stage 0, stage 1 is really the bulk of what we really want to do. That way, these patients aren't coming in behind the 8 ball. As most of you all may know, so when we think about clinical protocols and best practices overall, compression sleeves, pneumatic compression, decongestion therapy are just kind of the mainstay of what you all really talk about and what you all really do. As a screening program, and it depends on where you are, if you're in an academic institution or not, really what should be happening overall and what happens at Mayo Clinic or some of the higher these academic institutions really is having a program. So this is just an example of a program. And the thing you want to do is really identify if these are low risk patients, medium risk, or high risk, based off their symptoms and based off what they're having done. So if these patients are having axillary dissections, sentinel lymph node biopsies, radiation, chemotherapy, if they have a higher BMI, then really you want to put these do this risk assessment for these patients. What should be happening, which I don't think that we are doing enough. I do think there's a shortage of these therapists out there. But prehab, so these patients should be seen before surgery. They should be seen before any treatment or any surgical intervention that is happening. Obtaining baseline limb measurements, as we talked about before, performing risk assessments and evaluation for these patients, getting quality of life and symptom reports. This is important because if we have this prehab and they're seeing these therapists beforehand, once they see them in the first follow-up period or the continuous follow-up periods, then we have a baseline already there. And that is crucial for them. So once you identify what risk factor they're in, and their prehab appointment, they have their first follow-up, And then you really kind of do these arm value measurements as well. And based off these, we can say, all right, if this patient is low risk, they might only need to see us once a year, maybe every 6 months. Medium risk compared to high risk, when we think about high risk patients, they should be seen every 3 to 6 months. This is just a example protocol. It could be every 2 to 3 weeks, could be every week, depending on what your protocol is at your facility. As I talked about kind of what goes on in my practice. So usually I'm the very first person to see them, probably 90% of the time. I am the first doctor or physician to see these patients. So they'll see me, they'll kind of go around the gauntlet. They'll see the medical oncologist, radiation oncologist, plastic surgeon. And this is, particularly in my practice. So then they'll have surgery. At that point, as I said before, we will send them out and do this dual referral therapy at that time. This device is really customized to every patient. So what happens is we have our team. This is my office, and then some of the tactile team in the blue. And what happens is as part of the tactile team, they actually go out to the facility or go out to the patient's home. While they're in the patient's home, they measure them for their garments. They do arm measurements. And what happens is a couple weeks later, they come back, they show these patients how to put the equipment on, take the equipment off, how often they should use it, when they shouldn't use it as well. Kind of one side point to this is that this is my office manager, and I think that everybody would know that the office managers essentially run the show and what goes on. So she was on vacation during the time where we actually took this picture, and as I was working on this presentation, she said that if I didn't include this, then I probably wouldn't have a job the next day. So she actually makes the clinic go around during that time.
Dr. Davis, I have a quick question for you.
Yeah.
So I think just working as a patient advocate, we know that these cancer clinics are extremely busy. Oftentimes the questions that we get, are around, hey, I hear this, I want to do this, but how much extra work and how much extra time is it going to be for me in my clinic, to implement something like this? So would you mind answering that, or any best tips that you have from your clinic?
I think the way that you all have it, Tactile has it, is pretty seamless. My staff is really busy overall, and I try not to add any more burdensome steps than it should be. It definitely, if it affects the patient and it helps the patient, I'm all for it. But so as far as Tactile, usually it's already a pre-filled out form as well. Daniel is our rep in our area, so he comes in about once a week. We give, and him and so when I'm in surgery twice a week. So on my surgical days, we don't have any patients, he will come in and he'll talk to my MA, and they will go over all of the patients during that time. So maybe about 5 to 10 a week, and they would go through everything at that point. So we would give them in a HIPAA compliant way. They would give them all of their information, demographics, and then at that point right there, that's pretty much, from our standpoint, that's pretty much it. We have a dot phrase that I usually add into the notes, and pretty straightforward. I think every EMR has a dot phrase that you can essentially add. Daniel worked with us to come up with an effective and complete dot phrase at that time. So we put the dot phrase in each note. We have our notes. My MA usually prints those off and give them to Daniel. At that point, I would say that our job, from a Tactile referral standpoint, is complete. We really don't hear anything else. If it's insurance related, Tactile has a whole team that deals with insurance. Patients that no insurance, commercial insurance, Medicare, Medicaid, they deal with everything from that standpoint. I really don't hear anything from an insurance standpoint. Any prior authorizations, they have an entire department that will completely take care of that. So once I put my dot phrase as the provider, I put my dot phrase in, I don't hear anything else about it. My front desk staff, on the days that I'm in surgery, they fill the form out, which probably takes about 2 to 3 minutes per patient. Most of it is already pre-filled out. And then they give all this information to the local rep, which usually comes to my office about once a week. From that point, me personally, I don't do anything else. But the Tactile team on the back end essentially does everything from their standpoint. And then I still see these patients in the immediate post-op period, 3 months after, and I usually see them every 6 months for 2 years. And every time I see these patients back, I always talk about Tactile. They always, I have not had one person say anything negative about them. if they did say anything negative, it would be, hey, I really don't want to wear this device every single day for the rest of my life, but nothing directly about the garments or the company or anything like that. They have all had positive experiences with this. Um, from when Daniel actually takes care of the paperwork, they go out to the house, they fit them, as I talked about, with every patient is individualized, customized with a particular garment. Daniel goes back out, shows them how to put the device on, how to take it off, how often they should use it, and that's the main thing from my standpoint. Yeah, it probably takes me about 30 seconds to type a dot phrase in, if that. I have a conversation with the patients. I think that other providers that I talk to within my group, if you have a larger office, they usually have the MA or stuff. It's initially the providers bringing up that conversation. After that, then they have a provider or MA come in, or a physical therapist or COT come in and talk to them about lymphedema. But from my standpoint, actually documentation, probably 30 seconds.
Okay. I love to hear that, just because the impact you're making on your patients and really changing their survivorship journey just by doing this dual referral, and just hearing that it's not that much extra work for you guys. I think it's a win for everyone. So thank you.
No problem. I try to make things as simple as possible, especially on my staff. They are already, under a tremendous amount of stress. I think every oncology clinic is busy overall, but it is not that much extra work when I look at the bigger scheme of things for the impact that it does. To kind of go back to this, so this was this device is still out, probably least used overall. As we talked about, these patients, when we think about lymphedema, we really think about the extremities overall. With this, you essentially have the device goes over each extremity, and it starts at the most distal point and goes to the proximal point of that extremity. We're really missing that 47% of patients with the breast lymphedema, that truncal lymphedema. That's when the FlexiTouch actually came out, as one of the providers that commented. So you can see that left extremity is completely covered. That's the affected extremity. They have this pneumatic compression that goes from the most distal point to the proximal point. You also have the truncal portion. You also have the contralateral extremity portion, so the non-affected extremity as well. So these patients that are getting referred to you for this contralateral edema, this is probably the best thing that you can do for these patients. This was a randomized crossover trial, essentially looking at FlexiTouch compared to manual lymphatic drainage, but self-manual lymphatic drainage. Every lymphatic drainage is not equal. If you have a COT doing this versus a patient's spouse, you will have two totally different things happening. What this study did was it looked at a 14-day treatment effect. They looked at volume edema, so essentially they measured circumference around that extremity. 14 days later, they remeasured it and they looked at the reduction, and there was a large reduction compared to the manual self-lymphatic drainage. They also looked at weight loss as well. So these patients that actually had these treatment, they actually had the FlexiTouch, actually had a decrease in size. So this lymphatics was actually going into the circulatory system. They were excreting this out and they were losing weight. So all of this interstitial volume weight was being excreted. So this actually showed that compared to manual lymphatic drainage, not saying that we shouldn't do it, I think that we should do both. But for these patients who don't have that much access, who don't have that much commuting time, who live in a rural area, I think that FlexiTouch, in addition to manual lymphatic drainage, should work. It is beneficial and is the most beneficial overall, but this is saying that FlexiTouch definitely does help. Really three things when I talk about a product. So if a rep comes to me and he wants me to use a product, I really want to look at three things. So is the patient satisfied? Are they continuously using this device? And is this device doing what it was intended to do? What this study showed that 90% of patients were satisfied with this device. 96% actually had ongoing use. So even the 6% of patients that weren't satisfied continued to use this device as well. And then 95% of these patients still had, it did what it was supposed to do, still maintained or reduced that limb volume. So when we think about FlexiTouch overall, So it's clinically proven, as we talked about. There are additional studies that I didn't talk about. It's consistent. So these have repeatable and reliable effects. So we know that as soon as I put this device on and I program it, it'll have a consistent and reliable effect on you. It's convenient. So these patients usually have it, they put in their closet. If they're at home watching TV, what'll happen is they'll pull it out, they'll put it on for that hour and put it back. It's comprehensive. So not only do we have it for breast, we also have it for head and neck. They also have it for pelvic lymphedema, lower extremity lymphedema as well. And it's also comfortable. So even based off the feedback from clinicians and from patients that were using this, what they identified was that, hey, there's some improvements that could be made. They changed the garments and it's more comfortable. And as I said, it's not one size fits all. So every device is customized to each patient. So we think about call to action. So we don't know what we don't know. I think that awareness is key for everyone. I think you all are on this call, are really aware of what's going on. And I think us as clinicians and providers should be more keen to what's going on. Early detection, really we want to identify these patients in stage 0 and stage 1. That is the most important thing overall. Screening, at the next slide, we will talk about some screening things that we have as well for each patient. Education and treatment, I think that if we don't find out, we can't educate patients and we can't treat them appropriately. So it starts with us and it ends with you all. So some probing question, as I talked about. So this is breast cancer related lymphedema. So when we think about lymphedema overall, as I said, most people would think just the extremities, but when you're in stage 0, you don't necessarily see any edema at that point in time. And it's really these arm, and for me, arm and truncal symptoms. So these patients can have some arm swelling or arm heaviness or arm fatigue. And when we think about that, we just say, all right, you just had surgery and we kind of blow them off. But really, this is from a molecular level, really identifying the starting point of where lymphedema happens. So they can have truncal symptoms or arm symptoms. And really overall, when we think about this is that, hey, I know that this patient has surgery. I know that this patient will have radiation and may have chemotherapy. Let me essentially send these patients out to a therapist and they'll do this dual referral therapy at that time.
I say on this, Dr. Davis, if you can go back to the symptom screener. So I always tried to put myself, in the patient shoes. And I feel like if I was going through this breast cancer journey, I would really want to know that these are symptoms to look out for. And is this something I'm experiencing, there is help out there, and to bring this up to my doctor. So one thing that we sometimes do hear from providers is just, they don't want to provide this information to their patients because, they feel that this can really overwhelm their patients. Or maybe some patients are sensitive to this, and they're just going through so much as is. So would you have any advice for those clinicians or for those scenarios?
I think that, it's a disservice to not at least mention this, to these patients. As I talked about, our group name is Comprehensive Breast Center of Arizona, and we can't be comprehensive if we aren't providing that. I think that if it was, my mother or my family member, I would want them to have at least the access to it. And we all are busy. That's just the nature of the cancer field, the oncology field. But I think that we actually owe it to these patients overall, so they come to us. If we have to have that knowledge to at least look out for it. And maybe you don't have the knowledge and maybe you are too busy. But I would say that at least send them to somebody who can provide them that knowledge or that information. So it may not be us, but it may be somebody else. And good point with this, we do have this laminated in our office. So every patient that has surgery, we give them this symptom screener. And if they check off any box on here, we automatically send them out. Yeah. So it is very important and keen that we actually do screen these patients for it. If we aren't screening them for it, then nobody will.
Thank you.
Yeah, kind of lastly, I'll talk about, so lymphovenous bypass. Some of you may or may not have heard about this, but really what this is a kind of from a surgical prophylactic way to essentially help reduce the risk of lymphedema. What we really want to do is identify arm lymph nodes versus breast lymph nodes. The breast lymph nodes are really the cancerous ones that we want to identify. So B and D are essentially these arm lymphatics and lymph nodes, and A and C are the breast lymph nodes. The way this really works overall is we get ICG, so as we talked about the fluorescent studies in the arm that identifies the arm lymphatics, and then we get a dual tracer, so technetium and methylene blue within the breast. This is really important because we know about 20% of these patients have a sentinel lymph node biopsy. Their sentinel lymph node is actually an arm lymphatic. Any arm lymphatic that is removed, what happens is we identify that lymph node and vessel, and we dunk that lymphatic back into an axillary vein. And what happens is instead of truncating that and cutting that off, this lymphatic is actually dunked into this vein, this competent vein, and the arm lymphatic is really recirculated, so that reduces the risk of lymphedema overall. So in summary, what I really want to talk about is that lymphedema is really a prevalent thing overall. So from the first slide, we identified, we know that breast cancer is the #1 newly diagnosed cancer overall. We really should consider lymphedema risk in every single patient that we have. If they had surgery, they have a risk. If they have any trauma, they have a risk. Their BMI, radiation, chemotherapy. We really want to identify any risk factors overall. And last thing, really want to kind of consider any prophylactic surgeries to help reduce that risk of lymphedema.
Awesome. Thank you so much for all of that information, Dr. Davis.
Thank you.
This is Dr. Davis's info as well, if you do have any follow-up questions. So now I am going to go to the chat. We had several questions come through. So the first one is, do you want the patients to receive the FlexiTouch even if they are showing no signs of lymphedema?
That's a good question. I think that stage 0 is really a true thing. Stage 0 lymphedema. So this is really on a molecular level where you can have lymphedema before any progression. So if you have patients that, to answer your question, yes, I do think so. And really, if they have any symptoms based on that screener, if they had any surgery, knowing they're getting radiation, maybe chemo, I do think that it is beneficial for them. What I will say, it is hard to keep a patient wearing this garment, even though they don't show any signs of lymphedema. But having it is better than not having it. But if they have any of those symptoms, I think that should be a green light to go ahead and get the device.
Absolutely. So the next question is, can you discuss preventative measures for lymphedema prior to your surgery? And do you educate your patients on any of that?
So one of the preventative measures, so prehab is kind of, I wouldn't say a preventative measure, but kind of the start of where we need to go. Really, this lymphovenous bypass is one of those ways where we can, it's a prophylactic way to prevent lymphedema. There's really no 100%, foolproof to prevent lymphedema. I think it is, if you have trauma to that area, if you have surgery, then you're already at risk of having lymphedema. The most common thing that people are doing right now is this lymphovenous bypass. So any patient who has a complete axillary lymph node dissection, so removing every single lymph node, at that time, that is when I would do this lymphovenous bypass. Otherwise, there's no real foolproof way to prevent lymphedema.
Okay. So this question says, what about a recent study from India, which showed wearing a sleeve for 3 months post-op prophylactic reduced lymphedema onset? Do you ever recommend that? Are you familiar with that study?
I don't know that particular study. I think that, when we look at studies overall, I think we can't make a conclusion from one specific study. But I do know that I send them out to the therapist, and you probably have way more, knowledge from a therapy standpoint. But sleeves are important for some patients, especially kind of throughout the day, depending on their lymphedema. I can't necessarily speak on that study overall since I don't know that one specifically.
We did have a couple of questions come through when you were speaking of the dot phrase. So it's dot phrase in quotations, and it says, "What is your dot phrase?"
I can't. So I think every dot phrase is a little different. And I'm not, if everyone's not familiar with a dot phrase, essentially what a dot phrase is looking is a phrase that we have, and I have Epic. So in our Epic system is dot JD for John Davis, and then I usually put tactile. And essentially that phrase pops up in, it's like a signature. So it pops in, and essentially it talks about these patients that they had surgery. They have their, quote unquote hits, so radiation, things like that, and that we sent them out for physical therapy. And usually at this time, they've already tried and failed just kind of the original compression overall. So my dot phrase includes that if you have a device and you have a rep in that area, they have their phrases that they can give you. But I have not had any issues or any pushback with any insurance companies or anything like that. But essentially Daniel, who is our rep in our territory, he helped us create a dot phrase, and they have a bunch of depending on insurances and things like that. But I have a single dot phrase that I had from Tactile, the rep, and they will help you out.
Okay, awesome, thank you. So this one is interesting. At what point in rehab would you recommend a lymphovenous bypass surgery for the patient?
Yeah. So they have their, really, this is more prophylactic. This lymphovenous bypass is prophylactic. At certain institutions, what they're doing. So when you have stage two or greater, and they've already tried or exhausted all of their conservative measures, so going to physical therapy, decongestive therapy, compressive therapy, pneumatic garments, all of those have completely failed. Then there are certain centers where they have plastic surgeons and microvascular surgeons where really they do lymph node transfers at that point. So lymphovenous bypass is a prophylactic thing. So before they get lymphedema, and these lymph node transfers where they use abdominal lymph nodes or lymph nodes from the neck, these are done at stage 2, 3, or 4. Really, you want to try to prevent them from getting to stage 3, but I would say that ideally at stage 2 or 3 is really where you want to get these patients and have them do their lymph node transfers.
Is there a specific time frame that lymphedema will be less likely to occur after surgery?
So lymphedema is a progression overall. So I think that some patients, based off their genetics, based off their risk factors, they're just bound to have it. And some patients aren't. So really, when I think about this, is this a percentage? So 50% may have this risk of getting based off of their adjuvant treatments. Doesn't mean that every single person that has this 50% will get it. But usually that upfront really is when I talk about this kind of stage 0 and stage 1, really is where we should catch these patients at. But if they have these risk factors, if we look at the symptom screener and they have any of those symptoms, sending them out to get a device is really the main thing. And I would really kind of have a thorough conversation to say, you're having symptoms already, and this is 1 month out. Really, we should kind of get you a device, and we should send you to a therapist so you don't get to stage 1 or stage 2.
Mm-hmm. So kind of along those lines, this attendee asked, don't you want the patient to go through complete decongestive therapy first prior to using a pump?
I think that I think decongestive therapy is a good thing as well. But I really think that I'm not saying that we should use the Flexi Touch instead of. I'm saying we should use this in combination with. Mm-hmm. So I think that, are they coming to you every single day for decongestive therapy? Probably not. But what I would say is that I think that these patients, it shouldn't be or, it should be a and. So these patients should be getting dual referred at the same time. If they're at home, a lot of patients are much more comfortable at home, kind of doing things at home. There are a limited amount of therapists out there that do a good job at decongestive therapy and manual lymphatic drainage. So if we can have some bridge between these patients from when they see you one time and they see you the next time, I think that's a big help overall. So it shouldn't be a or, it should be a and.
And at Tactile too, that's definitely our messaging of we want every single patient to see a CLT. We want every single patient to go through complete decongestive therapy. But what about those patients that don't make it? We have to have something for those patients as well, or patients that are on a wait list to get into therapy. Let's see what else. So in addition to using the Flexi Touch, do you also recommend compression sleeve for stage 0 lymphedema? And if yes, what is the wearing schedule that you typically recommend?
So I think that it's as I was saying before, it's really hard to get a patient to do anything if they aren't showing these signs or symptoms. Um, for I would have them talk to the CLT or therapist about that and their individual risk factors and things like that. To answer your question, I'll probably say no, but I think that having some therapy at home intermittently would probably be best overall. But it would be extremely hard for a patient to consistently wear a sleeve when they don't have any lymphedema in states, or when they have stage 0 lymphedema and they aren't showing any external signs overall.
Mhm. So this one is, I've noticed the lymphedema after radiation therapy is very difficult to manage, even with a compression pump. Do you have any other recommendations at all for those patients?
Yeah. Usually with the compression pump, right after radiation, we usually say about 4 weeks between the end of radiation and to the time where they're wearing this flexi touch. So you'll have surgery, they'll have some recovery, and depending on, they usually have radiation within that 4 weeks, they should be getting fitted. But these patients really shouldn't be, based off, sunburn and kind of any radiation damage and things like that, really shouldn't be having a flexi touch or any kind of contact overall, really with any devices until that 4 weeks. I think if they came to a therapist and had MLD or any other adjuvant treatments with that, might be beneficial, because as a person that's actually doing it, you can see exactly where they have more radiation damage at, but the device really is meant for 4 weeks afterwards.
Okay. And then do you have your patients do CDT pre and post surgery, lymph node transfer surgeries?
So I don't perform the lymph node transfer surgeries, but these patients, ironically, I was at Stanford last week with a physician who actually does these lymph node transfers, and yes, they did the decongestive therapy and things like that before surgery and afterwards. It's very delicate after you do a lymph node transfer, because you want that lymph node to be viable. So essentially for about 3 weeks after surgery, this patient is, if it's the upper extremity or lower extremity, these extremities are elevated just from flow, just to have gravity help with that. Afterwards, they are on lifelong therapy, decongestive therapy.
And then I think this is the last question. Do you refer all of your breast cancer surgery patients to tactile, or do you just refer those with early signs of lymphedema?
So for me personally, I think that if and what I do is, if you, not necessarily every single patient that has breast cancer, but if they have surgery and that additional treatment, then I usually do. So if they're having surgery and radiation, then I will. Surgery and chemotherapy. I don't think that every single person needs it, but what I identified was that if I did a lumpectomy, probably almost majority of all my lumpectomies do really well, no issues. But if they had any radiation, if they had any chemotherapy, if they had any adjuvant treatments with that, then I do.
Okay. And I think that's important to note too, just because you are referring a patient to tactile, that doesn't necessarily mean that they have to get a pump. Sometimes it's, just trying the device, it's some additional education for lymphedema. And that just really helps the patient and their experience overall. Any other last comments, Dr. Davis?
I think that, and I talk for this company, not the main reason I really do is because I do think that it is one of those under identified problems that we do have. Lymphedema affects a lot of patients, and I think that we aren't treating these patients appropriately by playing hot potato and letting them go from one provider to the next. It really is our job to help get them to a therapist, to help get them to a lymphedema specialist, overall help them get them to tactile. Every patient may not be a good tactile candidate, but I think that they should at least have the information or information to get to one.
Awesome. Well, that concludes our program tonight. Just want to thank you all so much for attending. We hope that this information was very insightful and can benefit you as providers and also your patients. Tactile, we are very passionate about educating on lymphedema and also with survivorship. So you can find additional webinars and resources for your patients, similar to what Dr. Davis shared today on our website at tactilemedical.com. And if you have any follow-up questions, please feel free to reach out, and we will be sending a survey out as well. And especially if there's anything you would like to learn about in the future, let us know. So thank you all so much, and we hope you have an amazing evening.